and gentlemen, Assalamu alaikum, and a very good morning to you all. My name is Ronika Devi Yukrani, a third-year medical student at Aga Khan University and currently a co-member of the Surgery Interest Group. I would like to take this opportunity to welcome you all to the student session of the 6th Annual Surgical Conference. Continuing the tradition from past conferences, we have a session that has been specially designed while keeping students' interest in mind. We have 2 talks planned for you today, as well as an interview and a panel discussion. We hope that by the end of today's session, you take away vision and direction about your role in surgical education and training while transitioning into a new era as a student and ASMO in the future. So without further ado, let's get started. We start our day with opening remarks by Ms. Maheen Mansoor, a final year medical student at the Aga Khan University, who will briefly introduce this session. She is the convener of the Surgery Interest Group. Over the last 5 years, Surgery Interest Group has grown under the mentorship of our esteemed faculty members and works towards promoting interest in the field of surgery amongst our student body. Ms. Maheen Mansoor has organized numerous surgical workshops for her fellow students and played a key role in organizing annual surgical conferences, as well as this one. Ladies and gentlemen, Ms. Maheen Mansoor.
To put ourselves under surgeon's scalpel requires an immense amount of trust to put into the surgeon. So if any of us want to be on the other side of the table, we better make sure that we're worth it. This year's conference theme, Surgical Education and Training, is of something of key importance to inspiring surgeons like us present today. Assalamu alaikum, and a very good morning to all of you present here today. I'm Maheen Mansoor, the current convener for the Surgery Interest Group at AKU, and it is my pleasure to welcome you all to the 6th Annual Surgical Conference Student Session. So this year, our session would be focusing on transitioning into a new era of surgery and training. Last year, we went through some unprecedented times where the whole medical world was thrown into a maze, and everyone had to find their way out. Given the progress this year, better supportive care, a plethora of research, and several vaccines, the medical community has proven its mettle, which inspired all of us as students. Soldiers are now being replaced for doctors, and very soon we are going to be a part of this force. However, with these changing times and situations, one does ponder, how will this affect our training subsequent to our graduation? We also think if we are cut out for this responsibility and pressure. This becomes an even more urgent question for aspiring surgeons as there's very little room for mistakes in this area. What helps in figuring out these questions is a form of support from both your peers and your mentors in terms of advice, opinions, and knowledge. The Surgery Interest Group, founded in 2017 by Dr. Aisha Kudusi, serves just that purpose of having a little community for surgical enthusiasts. So it is my honor today to share our journey with you all and introduce my team, without whom none of this would have been possible. So last year, we organized ourselves into 5 departments, namely the Education and Skills Development, Alumni Outreach, Research, Event Management, and Media and Publications. So before the pandemic hit us, we had already organized 2 international conferences. We had a Surgery Olympics. And during the course of the year, we did 16 talks and panel discussions with 5 workshops. As the pandemic hit us, we created an online series of talks called Surgery Saturdays. We launched a SIG ambassadors program all over Pakistan. We also created international partnerships, and our talks were ACCME accredited. And we also created a website. SIG joined the American College of Surgeons International SIG Directory. We joined the Association of Women Surgeons and the IASSS. Surgery Saturdays brought in 1,500 participants from 22 medical colleges from all across Pakistan, all of whom were ACCME accredited. We had workshops on suturing and knot tying, email writing, surgery etiquettes, Foley's catheter insertions, and we had our surgery Olympics. Currently, we have 150 ambassadors from 67 medical colleges from all across Pakistan, all provinces, small and large areas included. And obviously, none of this would have been possible without our patrons, without their unwavering support and mentorship for us. Dr. Amir Sharif, Dr. Ather Enam, and Dr. Sadaf Khan, we're very thankful to you all. Our advisor, Dr. Gulzar Lakhani, is always there for us, and Mr. Sharif Charania, who's our go-to person for any and every problem. So we're again very thankful for them. Dr. Hamad Ather and Dr. Abdul Sattar played a great role in supporting us and being super approachable throughout the course of this conference. And this is why this whole thing took place. And of course, last but not the least, the team, without who are the pillars of the surgery interest group and who have created this session today. We, from the top right, we have Musab Munir, who is the General Secretary for the Surgery Interest Group, followed by Asma Merchant, who is our treasurer, followed by me, and On Mohammed, who's the senior core. Ali bin Abdul Jabbar is the leader for the Alumni Outreach Department. Manzar Abbas is leading the Media and Publication Department. Seher Virani is leading the Education and Skills Development Department. Ronika is leading the Research Department. And Aisha Akbar is leading the Event Administration Department. And we have Usama Wakar, Iman Farhan, Javeria Tariq, Muskan Kadir, and Hajra Arshad, who are junior core members, and they play an essential part in doing all the work around that we need to get done. So you can get to us through our email, through our Facebook page, Instagram page, Twitter, or through our website. And thank you so much for your time. I hope you all have a great session today. Thank you.
Thank you, Maheen. Moving on, we have Dr. Adil Haider, a graduate of the class of 1998, the Dean of Medical College, who is an accomplished trauma and acute care surgeon and a public health researcher. Dr. Haider has also been recognized for his work in the area of disparities in access to life-saving surgery. In 2017, he was awarded the Ellis Island Medal of Honor, previously won by 7 US presidents and 2 Nobel Prize winners. Please welcome Dr. Adil Haider, Dean of Medical College.
Assalamu alaikum. It's such a pleasure to be here. I'm trying to see which camera is on me so that I can look at the camera. All right, is it that one? Which one is it? All right, perfect. Bismillahirrahmanirrahim. It's really a pleasure to be here. I want to acknowledge the presence of the patron of the SIG, our Professor of Surgery and Department of Surgery Chair, Dr. Ather Enam. I see our conference chair, Professor Hamad Ather, and our co-chairs, Dr. Abda and Dr. Fazli. I see several leaders from the SIG, and I want to acknowledge your presence. The convener, Maheen, congratulations on putting all this together. Veronica from Education, Asma from the Treasury, good that you take care of the money. And of course, Manzar, I think, is running around here taking care of media stuff. So congratulations to all of you on putting together an excellent conference. I start with a bit of a confession. You know, my presence here as Dean of AKU has a lot to do with the Surgical Interest Group. In fact, it was the SIG and SRF, the Students Research Forum, that had invited me for a talk when I happened to be in Pakistan at another university giving a talk. You invited me on Facebook and said, hey, could you, since you're here, could you come over here in the afternoon? And that, returning to AKU, led one thing to another, including Nihari at Professor Ather Enam's house later that night, where I didn't go to my hosts who invited me. I went to your house instead, and I ended up coming back to AKU. So thank you very much for that. Another example of how the virtual world sometimes influences what actually happens. Now, you've given me a nice list of things I can talk about. And one of them has to do with the overview of your journey with respect to innovations in surgical education. And I think that instead of talking about the innovations, what I want to focus on are three short stories from my time as a medical student right here at AKU and how they informed my current job. And the reason why I'm doing that is because I got to tell you, I love my job. I think when I go to sleep at night, I pray to Allah, thanking Allah for the opportunity to do what I get to do every single day. And I hope that all of us can have these kinds of careers. And so I'm going to give you three anecdotes. The first is in the operating room. I'm not going to name the surgeon. Some of you figure out who it was. This is back in 1997. This is a young surgeon, now full professor. And this was a really difficult case. The patient was in full DIC, was not coagulating. And at the end, the patient could not survive. I saw the steely resolve throughout that operation. I saw that surgeon never lose their focus. And I saw that surgeon never give up till the very end when the game was over. But then I saw that surgeon go outside and cry, not in front of the patient, not in front of the students, although I did see him. But in his own moment, he showed an incredible compassion of what it meant to be a surgeon, what it meant to really take care of another human being. We are not technical butchers. We are physicians who take care of humans. The second was with Dr. Hasnan, and some of you will remember this. Hasnan, Dr. Hasnan Zafar, who's now our Chief Patient Safety Quality Officer, it's interesting that he has that job now because, he didn't always follow the rules. I remember he was the trauma fellow. A very sick patient came in. We did not have a protocol for doing an emergency department thoracotomy, but he did one nevertheless because he wanted to give this patient who came in extremis and who had a very, very slim chance of survival the opportunity to survive. Now, later on, many people questioned the decision. Many people said, why did you do it? How did you bring the resources? And all sorts of things. But what I learned from that one was never to give up. And even if you have to sort of develop a protocol as you go, do it because it might save a life. The third thing I learned right here in medical school was perhaps something that many of you have already been through. And that is being in the operating room as the surgeon for the first time. Now, for me, it came as a third-year medical student when Dr. Tahir Shafi left me to close the skin on a patient. I will never forget that moment. He jokingly said to me, it was on the arm. And he jokingly said to me, don't hit the aorta. And I thought for a second, the aorta doesn't go through the arm. But the point is that you will remember these moments when you get to be the person who's in charge. Now, this was in the late 90s when I was a medical student. And I'm going to fast forward 10 years after doing another graduate degree, 5 years of surgical residency, 2 different fellowships, one in trauma and critical care, one in trauma, the other in critical care. And now I'm a young surgeon in a busy urban center in the United States. One night, we had the occasion where my pager went off like it always goes. And it said, 19M GSW ETA 2 minutes. 19-year-old male, gunshot wound, 2 minutes estimated time of arrival. I run down to the trauma bay. The chief resident is there. The patient's already being offloaded from the ambulance gurney onto the regular stretcher. And Catherine Pesh, the chief resident, looks at me. I look at the paramedic and say, how long has the patient been down? The patient was pulseless. They said 7 minutes. Many of you will remember that the upper limit of time mostly is about 10 minutes for a penetrating injury to the chest. I just nodded at Catherine and she started an ED thoracotomy, much like Hasnan. She opened up the chest, she got in there, she delivered the heart in like that. But there was not going to be a big save that day. The injuries were just too devastating. And despite a great attempt, we could not fix it. Now, pronounced the patient dead. And then we talked about how we're going to give news to this patient, how we're going to give news to this patient's family that this young man had died. And we decided that Catherine would be giving the news because she was the chief doing the case. The ED attending was with me as well. And then there were two medical students. And I always like to take the medical students so that they can see what it's like when you have to give this terrible news to a family. So it's Catherine going in the room, two medical students, the attending, it happens that they're all women, and the attending is even taller than me, the ED attending, and I'm behind them. We walk in, and as soon as we walk in, there's an elderly woman sitting there in this room that have 15, 16 people in it. And the elderly woman looks at me and says, "Oh my God, it's him. He's dead." All of a sudden, pandemonium breaks out. Everybody gets upset. People start walking out of the room. The chief resident says, I didn't even say anything. Like, she kind of mouths words. I didn't say anything. What happened? So I go down and sit next to this older woman. She's the matriarch of this large family. And I sit down next to her, trying to understand how she knew what had happened. And turns out that she said, "Remember me?" And of course I remembered her. She was another patient's, Kenny G's grandmother. Kenny G had been shot at this town where I worked 6 months before. He, though, had been shot in the liver. He came to the emergency department. We took him right upstairs. He coded on the OR table, but we had the bleeding under control. And we were able to fix the issue. He ended up with an open abdomen and multiple takebacks, and he did survive. But the thing that this patient remembered was that when I came out to talk about this patient, Kenny G, who survived, I came out with my chest held high, the same way that when Tahir Shafi let me do my first stitches. I was exuberant, I was excited. I was like, we did this incredible operation. The liver was filleted in two, but we were able to fix the patient survived. But when I lost the patient who had the gunshot to the chest, I came out of the room and I was looking down on the floor. And she, just by my facial expression, was able to tell that I wasn't successful. The key point here is that when you find something that you really like and you understand what your passion is, then you realize that this is something I need to invest in. And my journey back to AKU is partly derived by that, because what happened, and you just heard about my work on healthcare disparities, these experiences led all of my work on healthcare disparities to understand why certain patients have worse outcomes than others. In this case, it's minority males who suffer endemic violence in the United States. But then when I got back to Pakistan and I came to your talk at the SRF and the SIG, it reminded me of the opportunity that remains here in Pakistan. And so it was not a big choice. It was hardly a choice when presented with the opportunity to work on inequality in a way that only we can do here in Pakistan. So the first thing that I wanted to just leave you with is that if you can figure out, as time goes on, if you find what really bothers you, and it turned out that in my medical college interview here at Aga Khan, I remember telling Dr. Villani that inequality really bothers me. That trend led throughout my career. So if you can figure out the thing that really bothers you, that will ensure you that you have a job that you always love. The second thing here was learning how to do your job. And that's where we come to the topic at hand. You see, becoming a surgeon is a lifelong skill. And what you have to do is, there is going to be a lot of things that you're going to learn. There are going to be a lot of things we're going to talk about, simulation, all these things. But what you're going to most importantly pick out is that when you work with physicians, work with other surgeons, there are going to be certain positive traits that you're going to love. And the key is to keep those positive traits whenever you see them. Do what works for you. Write them down, commit them to memory, and put them in my pocket. I literally, when I see something very important, I literally do this weird thing where I just somehow put that memory in my pocket. I don't know how it works, but somehow it reminds me. So you're going to be faced with lots of surgeons. And when you see something that you really like, try to commit that to memory. It might be something as simple as just how to close the abdomen. The other day, I had the opportunity to be operating with one of our chief residents here at AKU, and I did a way that I know how to close the abdomen. She hadn't seen that before, and later on, she came and told me 6 months after, or maybe 2 months after, how she has begun closing the abdomens that way, and it's really made it faster for her. So keep those things in mind. The key is that throughout the journey, it is to your own self to master the trade. You have to recognize that now you're senior medical students, you're junior doctors. Nobody's going to come spoon feed you anymore. You have to pick out the important things to develop mastery. And finally, these three stories represent something much larger. And that is that it takes a community to grow up in, that it takes a bunch of different people from whom you're going to learn different skills with, and who will help you propel to the next level. These events, like the surgical interest group, I'm thrilled to see that this is beyond AKU, that this is across Pakistan, that there are probably 1,000, 1,500 people registered even for this conference. I hope that you will band together like a caravan, like a group of people on a mission, who, when hard times come, support each other, and when good times happen, enjoy each other. And I've seen how the surgical interest group and many other groups have come together through this whole pandemic. In fact, this group, the Students Against COVID, has done incredible work. And so as you move forward, I'm going to recommend that collaborate more than compete. In fact, there's this new mantra: collaboration is the new competition. Because only when we lift each other up, especially when we're in Pakistan, if you're looking to get better training, you're trying to find some new opportunities, let each other know about them. Because when you build this caravan of support, then it is much easier to move forward. So I'm going to end. I know my time is just about 15 minutes right now. I'm going to end with just reminding three things from those three anecdotes that I learned very early on when I was in medical college, rotating through the Department of Surgery. The first, and let your passion come to you. If something really bothers you, even if it's not the most exciting thing. I had a friend who, just loved public health. And we told him, and his name is Saad bin Umar, we told him, look, you need to at least do a residency. And he said, no, I care about public health. I want to learn about vaccine safety. I want to do this. And now if you Google Professor Saad bin Umar, director of the Emory Center for Global Health, you'll see he's all over TV all the time, because when the pandemic hit, he is the voice of reason. He is the person saying what we should be doing. And all the things that we used to advise him on, don't make a difference anymore. He made the right choice because he followed his passion. But the other thing that happened with him is that he mastered his trade. He got a PhD in vaccinology after going through medical college. So mastering that is very important. And finally, he did, just like me, build a caravan, build a group of people that supported him and helped him throughout his career. So I end with the wish that you have a job that you love every day. Thank you so much, and Khuda Hafiz.
Thank you, Dr. Haider, for an inspirational talk. Up next, we have Dr. Ghulam Abbas for the talk titled, What Does the Future in Surgical Education Look Like? Dr. Abbas is an American board-certified cardiothoracic surgeon working at West Virginia University Hospital. He is internationally recognized for robotic lung-sparing surgery for lung cancer and minimally invasive esophagectomy for esophageal cancer. In 2017, he was named Chief of Thoracic Surgery and Director of Surgical Thoracic Oncology at the West Virginia University Hospital. Please welcome Dr. Ghulam Abbas.
Hello, this is Ghulam Abbas, thoracic surgeon from West Virginia University. I would like to thank the committee for the opportunity to give this talk. My topic today is the surgical education, what is the future? Currently, the way the surgical training is that the resident or trainee spends time in the hospital first observing the procedures, then performing them under supervision, and ultimately becoming independent. The reputation of the cases leads to the competency, and there's a learning curve. So this is the way the training has been for centuries. Uh, the future will bring changes, and there will be less tolerance for learning curve on humans, on the patients. To change something which has been there for years, you need a disruptive innovation always. It has to be a disaster or a disruptive innovation that change the way people act or stop doing things which they've been doing for years. If you look at the disruptive innovation beside internet, the smartphone is a disruptive innovations. The kids under 25 year of age cannot imagine living without a cell phone, or they cannot imagine life without a smartphone. If you look at the other examples, the drone is a disruptive innovation. It's been used in different industries for different tasks. Similarly, the food industry, this Impossible Whopper became as a disruptive innovation. It's a meat tasting, meatless burger patty. And in surgical field, the robot has become a disruptive invention. The way the surgery is being done nowadays is completely different 30 years ago. Most of the procedures are geared toward the minimally invasive digital approach. And this Microsoft HoloLens, this is what the future of education is. The future of education, medical education, would not be on the patients or through the books. It will be all in virtual reality or mixed reality. So if you look at the future of surgery, it will be all digital surgery, robot, virtual reality, augmented reality, mixed reality. This is the way surgery will be taught in future, and the trainees will learn. Beside, before we go further, let's talk about the definition of these uh, uh, terms. The extended reality include all these reality applications. Virtual reality is where you create an artificial world where the user is completely immersed in the digital world and interact in a realistic manner. So it's an artificial world, but the user is interacting in a realistic manner and is completely immersed into that virtual reality or that environment and is surrounded by that environment. The augmented reality, on the other end, is uh, is a real world augmented with the computer generated images. Like you can point your cell phone or a smartphone toward a building, and then the computer generated uh, messages will come and tell you that building, what the history of that building is, what's in the building, what there's a cafeteria in it or not. The mixed reality is a combination of these two, the extension of augmented reality that allows real and virtual elements to interact in an environment. So if you talk about the robot, the word robot is a Czech word. I'll tell you in a second. The robot itself, the surgical robot, is not a true robot, it's a telemanipulator. By definition, a robot is a machine which is capable of performing independent tasks. The surgical robot is not a robot, it's a telemanipulator. It's more of a master and a slave uh, system where the slave is the machine and it mimics the finger movement of the master who's sitting on the console. Uh, so, as I said, the word robot came in 1921 as a Czech word that means is a forced labor, and subsequently was used in the science fictions. And the first true FDA approved robot was the Robodoc. Robodoc was a robot used for femur extractions during the hip replacement. It was used in orthopedic surgery. Then the NASA and US Army got involved because they wanted to use a robot as an independent machine in a battlefield. That was a dream which hasn't come true yet. The first real use of telerobotic was performed in 2001. A transatlantic cholecystectomy was performed where the surgeon sitting in New York in Mount Sinai Hospital performed a cholecystectomy in Strasbourg in France. And that was in 2000, like 21 years ago with that internet cable technology. And imagine what we have now. And that will be the future, that there'll be telerobotic surgeries done in remote part of the world by surgeons sitting in a different part of the world. And as the robot is maturing, and we see we are and where we're going in future. Right now, we just perform the procedure, but in future, the navigation systems will be augmented on the robot. There will be an integrated surgical planning. You can plan the surgery before performing the procedure, and the images would be uploaded on the computer that the robot will help you identify, for example, the lung tumor, where it's in the lung, which segment it is, and where the segmental vessels are. So the robot will help you. And right now there's no haptic tactile feedback, but that's coming too. And ultimately the goal in the robots will be that millions of these procedures will be fed on the robot, and in one day the robot will independently perform these procedures. So these are different companies coming up with different robots. This is the Da Vinci single port robot. It's one port with all these instruments. There's a flexible camera, and these are the flexible instruments where you can perform different surgeries. Right now is FDA approved for head and neck surgery, where the ENT surgeons are performing laryngectomies, and urology is using it for prostatectomies. This is the Ion, which is another generation of robot. It's endoluminal robots. Like this is a particular one is for lung, where the lung, where this robotic is flexible robot bronchoscope is introduced through the endotracheal tube into the bronchus, and it can reach to the periphery of the lung and perform a lung biopsy or perform an ablation of the lung tumor. So this is a flexible, and the surgeon is, or the pulmonologist is using a Xbox remote operator, and it will proceed to the periphery of the lung. So if you look at every specialty, they're performing robotic procedure. If you look at thoracic, we're doing first rib resection, segmentectomy, lobectomy, esophagectomy, hilar myotomy, thymectomy, hiatal hernia repair, diaphragmatic plication, chest wall resection, and multiple other procedures are being done using the robot. Similarly, in ENT, urology, cardiac, gynecology, general surgery. This is an example of a robotic esophagectomy, how it changing the procedure, how we perform the esophagectomy. Are you seeing the right cruise, left cruise, esophagus, post-chemo radiation esophageal cancer patient? The esophagus is being mobilized. And this is mobilizing the conduit. And that's the conduit stapled, finishing up the abdominal part. And then this is the chest part where the esophagus is completely dissected. And then we're bringing the conduit and performing the anastomosis in the chest. It's using a circular stapler. And this is a lung robotic segmentectomy. I think among, you can do a very good VATS lobectomy, but as far as this segmentectomy goes, robot does have certain advantages. So just an example that how it helps dissect the structures in complex procedures. So this is the pulmonary artery, anterior segmental branches, apical segmental branches. That's the zygous vein, vena cava. And in this case, we're using the robotic staplers, taking the apical segmental branches and leaving the anterior segmental branches. That's the vein we're working on. That's the apical segmental bronchus. So it's not the whole robotic bronchus, lobe bronchus. This is the segmental bronchus, which is being stapled. So in future, what's happening now, there's more and more companies coming with this technology where you can mimic the operation before performing the surgery. So the trainees can log into this simulation systems and perform the right upper lobe apical segmentectomy or esophagectomy before they scrub into the case. So you already have done it. They're not high quality right now, I will say, but the way the simulation industry is going, it will be almost realistic in near future. And then the other thing is, like, as I said, there will be less tolerance for a learning curve. There are more and more institutions coming with, like our institution, we have a perfused cadaver lab where the trainees, like every month, they have a different specialty attending, taking them to the cadaver lab, and they're performing multiple procedures. Like this is a real scene where you mimicking a bleeding injection. So this is colored fluid in a fresh perfused cadaver. It's very close to the reality. And this is how it is done. You cannulate the groin, you can use the color fluid, or you can use the air. And the vessels will look like a real vessels. And with the air injection, you can actually simulate that pulsation sensation in the vessels. So we are looking at our general surgery residents. If you look at the number of complex cases, is decreasing across the United States. And these fresh tissue cadaver labs are helping residents to practice on these cadavers to compensate for the loss of operative experience, as more and more operations are done endovascularly or robotically, and the residents are getting less and less exposure. So what in this study they did the pre and post knowledge test to assess the knowledge gained, and the surgical skills were evaluated pre and post cadaver lab. And you can see this, there was a statistically significant improvement in their skills. These was PGY4 residents. Their confidence level, their knowledge, their skills, everything improved. The tasks they performed, 93% complete the chest, the thoracic module, and then the abdominal module was completed in 90%. So that improve their ability. And in future, as I said, there will be less and less patient used for teaching. It will be all virtual or mixed reality. Here you're seeing it's not a real patient. This is a hologram of a patient. You're getting the active vitals, and the residents or the students will be taught with these hologram of the patients. They could create certain clinical situations, give you the information. Like this patient is a stroke module. So these things, this is the Microsoft HoloLens, giving you like a hologram of a patient, clinical situation, and the instructor will be leading the session and teaching how to do, how to perform these exams or what the clinical situation is. They're almost close to reality. And this is how the section of the lab will be.
Without the cadaver. Introducing Hollow Human, a companion product to the award-winning Complete Anatomy platform. Learning anatomy? Choose to learn via system or region. Then dive in and explore the world's most advanced 3D anatomy models. Discover the anatomy, structure by structure, in exquisite detail. Explore the depths and layers of the human body. Dissect your way through 12 interactive body systems and identify relationships between organs, tissues, and vessels. Learn detailed information about each anatomical structure. Teaching anatomy? Prepare specific views of the body and save as activity.
And then this is Microsoft HoloLens. I mean, this is mixed reality. And this is how things are going to be done in future. So Microsoft HoloLens, I would say, is a disruptive innovation, that this is going to change how things are. Using this technology, surgeons from different part of the world can be looking at the same hologram or same and participate in the same procedures. So this is a game-changing technology. And then similarly, like if you look into this technology, and this is augmented reality. I mean, you can see, perform all these. This is a headset, so it has a built-in surgical tracking system, which accurately tells you if you're implanting the screws in the spine at the right place. And let me show you how it works. So this, for example, putting these screws or the instruments in the spine, it shows you really exactly where you are without making a cut. And these technologies are getting better and better. And you can imagine how things will be performed in future using this multiple technologies. I would like to conclude here. I think this is our West Virginia University Heart and Vascular Institute, where my office is right here. The way the surgical education will be, it will be less dependent on the patient. We'll be learning more in a mixed reality environment. And the residents or trainees will be performing a lot of these procedures in mixed reality world before they get to operate on the real patients. Thank you very much for your time. And I hope the session goes well. I won't be able to participate. I apologize for that. Thank you.
Thank you, Dr. Abbas, for an interesting talk. We have a small question and answer segment for our esteemed keynote speaker, Dr. Haider. The first question is, what advice would you give to the medical students? We have few burning questions for Dr. Haider. The first question is, what advice would you give to medical students passionate in surgical specialties? What skills should we work on?
So I'm going to say something which is not going to excite people. And the number one skill is you have to read. The issue is that too many of us get so excited by, the robots and all sorts of funny, amazing technology, but you can't use that stuff effectively until you really know what's happening. Now, I know at the curriculum that the Aga Khan University is using and many other innovative medical colleges across Pakistan, and since I'm now involved with the PMC, I get to see some amazing work done across the country. There is a spiral curriculum. We are working on, for example, teaching anatomy during surgery and so on. So what I would say is that if you're a medical student and you have the opportunity to see a human operation, the most important thing is you should know more anatomy of that region than anybody else in the room. That's the first thing. It is essential and crucial. The second thing is you have to be on your game and in the moment. Even if you're not scrubbed in, you can't be on your phone or something. You have to be there waiting for the moment where you get to leap in and say something about the surgery, understand the surgery, learn about the surgery, and so on. And then the third thing is that if you know what case is coming up, you gotta read it in advance. And then to get the opportunity to participate in that care, you need to know more than the intern or chief resident. You need to spend time with the patient. You need to go see the patient post-operatively. You need to show what's called ownership. So I guess in a word, if you want to do well, you have to have ownership of the cases that you have the opportunity to participate in. That goes by studying the region, the anatomy, the operation, and how the patient does post-op. I know this is not the most exciting response, but honestly, that's where it starts. And if you master that, then everything else comes after.
Next question is, how do surgeons overcome the grief that comes up with a surgical profession?
So this is an important point that you brought up, and there certainly is a real amount of burnout amongst the surgeons. There is also a worry and a concern about loss of humanity, about loss of that connection that you develop with patients. And different people deal with it in different ways. Some people never personalize. Some people like me absolutely look at the humanity of the situation because we think that um, moves us. I think the way to do it, at least what I have learned on how to do it, is that you give it your best shot. When you are in the operating room, when you're with the patient, those moments. And I've seen, for example, um, I'll give you two examples. The other day, we had a very important meeting here, and we were signing an MOU with another big university. And the PI on the project is a well-known investigator who happens to also chair the Department of Anesthesia. And he was rotating in the COVID ICU, and the time had come. We were supposed to start. And I text him, "Where is he?" And they tell me he's in a family meeting and cannot be disturbed. And I was thinking to myself, his whole career, this whole big project, he's going to pay more attention to a family meeting because he's in the ICU and let this big MOU be on all sorts of other people, because in his mind, he is a doctor first. And that doctor-patient family relationship was so, so, so important. I've seen Dr. Sadaf Khan, who I get to work with a lot as a surgeon. She's the head of the MBBS program. I've seen her do exactly the same thing. So I think if you truly care about people, you give it your best shot, such that when you talk to the family, you can honestly say कि जी मैंने हर चीज की जो मैं कर सकता था, जो हम कर सकते थे, जो टीम कर सकती थी. If you're able to honestly say that, that is perhaps the best prevention from loss of humanization or burnout or dealing with that stress.
The last question is, where do you see the surgical specialties in next 10 years and how can students prepare for it?
So I think, and do I have a little time to answer this question? Yeah? Okay. I think I want to answer this question in three specific ways. The first is that we are going to see a sort of yo-yo between specialization and then back to becoming normal. What do I mean by that? Right now, for example, there are many fellowships, for example, for laparoscopic surgery. But over time, you're noticing that all those laparoscopic skills are getting incorporated into general surgery training, to the extent that you really shouldn't be training as a general surgeon unless you can do the core laparoscopic stuff. When I graduated, doing a laparoscopic hernia was something that was not a guaranteed thing before you graduated as a general surgeon. Now it would make no sense to graduate as a general surgeon without knowing how to do a laparoscopic surgery. So I think what we're going to see is that we're going to see some of this development of subspecialization based on instrumentation. Remember, a laparoscope is just an instrument. Just like you saw that robot, it is just an instrument. The key thing, again, is to develop the surgical mindset, when to learn, when to operate, and what is the right candidate for an operation, and how to manage that patient post-operatively. These are the core things that we must continue to focus on. And then the instruments that we use are almost like a byproduct of how that all is going to work. So I think so that's my first answer. You're going to see a sort of yo-yo effect of exactly how this training is going to work. The second important thing that we're going to notice is that certification is going to become even more important. And where you trained and what certification you have is going to hold a lot of sway. Over the past few decades, we've seen surgical training, especially in Pakistan, people got apprenticeships and they became surgeons. However, now more and more people are demanding that the person who operates on them have a true FCPS, which is our primary thing, or other international qualifications. So I think if you are a surgeon, and this is especially for students across the country, if you are faced with the choice to do training at a place which is a lesser known place, but where you're going to get real hands-on experience and that you're going to get the right credentials, go for that. Sometimes it's an easier sell, okay, oh, let me do the easier credential. I know there's a master's and this, those things are not going to work. You must have the FCPS qualification if you're going to be in Pakistan. That is absolutely crucial. And then if you're overseas or you have some sort of international qualification, then that needs to be something that the Pakistan Medical Commission actually recognizes. So that's my second point. We must focus on getting the right credentials. And then the third important point is, you see, nothing trumps talent. When you are training, the opportunity to train doesn't come back. So this opportunity to develop this talent. So we have so many surgeons here. And you're like, Professor Ather, what a great operation when he's in the OR. It's amazing where he does that. He didn't learn to operate that way when he was a professor. He worked and developed those skills when he was a resident. And the key is that you have to learn it yourself. The opportunity to train doesn't come back. Once you're done, you're done. Us waqt phir nahi learning hoti hai. So the key third point I want to make is that when you are in your training opportunity, you have to take it for everything that you can, because the opportunity to train is not going to come back. Sooner than you think, you'll be faced with a patient all on your own, and you will have to make life or death decisions. And that's not the time to go back and learn new skills. You have had to develop the skills. Aapka haath us waqt saaf hota hai, residency mein, baat mein nahi. I hope that answers the question. And again, thank you so much for having me here today.
Thank you, Dr. Haider, for interesting and motivational responses. We have sent an attendance form in the chat box for the participants. Please do fill the form to confirm your participation. Thank you. Next up, we have an interview with one of our very own graduates, Surgery Interest Group ex-convener, Dr. Arish Haider from the class of 2018. Ms. Aisha Akbar, core member of Surgery Interest Group, will be talking to him today about his interest in surgery and his journey after graduating from medical school. Over to Aisha.
Assalamu alaikum, everyone. I'm going to do a formal introduction for Dr. Arish Haider and then a personal one. So Dr. Arish Haider is a graduate from the batch of 2018 of our very own university, Aga Khan, and he was also the former convener of the Surgery Interest Group, which is what makes him so special for us, because it's like a full circle and he's coming back as having done this whole training arc, led SIG into what we are doing today. So he's actually part of the foundation of what we are doing today. He is an aspiring ENT surgeon in the making, and he did 1 year of internship at the AKUH, Aga Khan University Hospital, after heading to the UK, and he's been there working for the NHS. Currently, he is at the West Suffolk Hospital. Have I pronounced that correctly, Arish?
The West Suffolk Hospital, yeah.
Yeah. So that was the formal introduction. Arish, I've seen, has been one of the most passionate medical students that I ever got to witness and speak to. He was someone who used to scrub into the OR. He's also one of the most dynamic personalities at AKU and continues to be a dynamic alumnus. And so we are very pleased to have you here with us today, Arish. I'm just going to make it very casual and ask you, how are things? How are you doing? Where are you currently at? Let us know through your own words.
Well, before anything, I'd like to thank all of you guys for making this happen yet again for another year. The Student Interest Group is quite an integral part, I believe now, of the annual surgical conferences that we have at AKU. So well done to all of you guys for that. Thanks for having me on. It is quite an honor to be part of the conference as a speaker now. Formally ho gaya. Informally speaking, I'm good. Actually quite excellent, thankfully. Currently at home after a week on call. And things are good, yeah.
Right. So, Dr. Arish, can you tell us a little bit about your journey from being an AKU student, as well as a SIG convener, to now a surgical resident in training?
So when I was at AKU, unfortunately, there is a bit of a culture that encourages pressure. And of course, being as a first year student, I was from the get go, which I think is now the culture in quite a few universities. I was from the get go encouraged to not actually focus on my profs rather than focusing on my preparation for the STEP exams and the USMLEs, and from day one starting to think about my CV, building it towards going to the US. In third year, I was always into extracurriculars. I am not a very studious or a smart student, never was. This is something I think I pick up from a few of my family members as well. But in third year, I was lucky enough to be part of a conference in the Netherlands, which is where actually the bubble burst for me. I saw medical students coming in from all over the world, from all the way from Australia, New Zealand to Europe, America, and everything. And I saw what medical education really is abroad from an at an undergraduate level. That was where I realized that, it's not just working on yourself academically. University is supposed to be a time where you are studying, but you also find yourself. You explore your own personality. You find things that you like to do. You find opportunities like acting and music and um, event management. And it's not all just पढ़ाई. दुनिया में पढ़ाई के अलावा भी बहुत सारी चीजें हैं. और ये मैंने unfortunately I think पाकिस्तान के बाहर डिस्कवर किया. Speaks a lot for the education system that we have in place right now. From a systematic level के बचपन से लेके बड़े होके हमको यही सिखाया जाता है कि बेटा इस साल और अच्छा कर लो, अगले साल से बहुत अच्छा है. And then that happens all the way until you're 25, and by the time you're 25, life catches on and you realize that there is a lot of stuff that you should have done or could have done that you didn't. So when I went to the Netherlands for the conference, I made a lot of friends. I found out what priorities are for students abroad and how they do stuff there, which is what inspired me to actually look out over the horizon of the US. And I started thinking about other options. Very honestly, had Pakistan's own medical education system at this point been developed enough in terms of both support of the trainee financially and academically, and in the sense के अगर बहुत अच्छी quality of training होती पाकिस्तान में, which was recognized and was well competent, I don't think anybody would want to actually leave a place they call home. But then but because it is not that at the moment, unfortunately, I started exploring abroad. I got in touch with some people in the UK. I started exploring things here, and then right after graduating from AQ, I was lucky enough to come here and on a clinical attachment to really see things on the ground. And that is when I got further inspired to come to a place like the UK, because even though the system here is different, training here generally takes longer than the US or Pakistan even. I have found that people here do pay a little more attention to developing themselves more holistically rather than just academically, which is one of the things that I found very close to resonate with me, which brought me here. Other than that, there was also the idea of coming to a country where it might be a little logistically easy to come and go, meet my family, this, that, and everything. So there was a lot of factors like that as well. But yeah, that is essentially my journey to come here. I do have a lot of mentors at AKU to thank for this, because they encouraged me to pursue, because the theme of my mentors was always pursue the career you want, don't compromise your choice of field.
Yes.
And second, always have your long-term goals always in view. So I actually have Dr. Mumtaz Jamshed Khan to thank about for all of this, because he's an ENT surgeon. He's a professor who's a graduate of AKU, went to the US, trained there. And when I went to him, when I got to know him, he was all for me going to the US for training. But then when I went to him with the idea of Dr. Mumtaz, I'm exploring the UK as an option, he was absolutely for that as well. He said, you know what, इस बात में भी sense है कि वहाँ जाने की तुम कोशिश करोगे, so go for it. He was never somebody who was narrow-minded and it wasn't one of those people who say, you know, we went through this, so you should go through this. So I think encouragement from mentors is also a big part of it.
Thank you. That was a very insightful answer, and I think a very good narrative about how, there are multiple options, and we kind of sell ourselves short from exploring them. So I think that that's a really good take-home message for us from your journey, and I hope more people look into that. So before I continue, Dr. Adil Haider actually has a question to ask you. So I'd like to call upon Dr. Adil Haider to raise that question.
Arish, great to see you, man.
Nice to see you.
So I'm always so impressed with how you've crafted your journey, and we all have great hopes for you. I have a very simple question. Did the internship you did, was that beneficial to you, or you think that you could have gone to this program a year earlier?
Thank you for that. Actually, that's a big point. That's actually a lot of people who ask me about the UK ask me about internship. First things first, legally, you have to have an internship to be fully registered with the GMC here. And B, I think to my juniors, especially at AKU and all of the other medical students from all over the country listening, I would encourage an internship, especially at Aga Khan, because Aga Khan mein you have a culture of accountability, responsibility, and mentorship that you don't often find, unfortunately, in other parts of the country, which is something that set me up very, very well for coming to the UK. The West Suffolk Hospital, where I'm working right now, is thankfully one of the more outstanding rated places in the NHS. And the system here is so similar to AKU. I was actually super impressed in retrospect with my internship, because not only is there an advantage of everything being online and digital healthcare systems, but there's also the entire environment of more patient focused care, in which you have a big part of that is patient communication, which I think not just in the undergraduate, but also in the internship and postgraduate programs at AKU is a big priority. Taking care of your patient, not just in the way of taking out their gallbladder, but also asking them, how does that make you feel, is a theme I found in the AKU internship was quite stressed upon. So yes, I would say that the AKU internship was one of the more essential experiences before coming to the UK. Thank you for that.
Thank you, Dr. Adil Haider, and thank you, Dr. Arish, for your answer. So this is a kind of a cliche question by now, but I think it's important to ask at some point. So how has COVID, kind of affected your training or changed the way you had anticipated it to be this year?
So I can't really compare to UK training pre-COVID, but because of COVID, fortunately, there's a lot of NHS discounts, so I save a lot of money. The second point of it is COVID has led to a bit of a transition from more interpersonal meetings and all to things that we're doing now online. And COVID in the UK has provided a lot of exposure for the general public as to what having an actual, public sector healthcare system means, and they've started supporting the NHS more. As a trainee, however, I found that in the UK, there's a lot of the culture is about documentation and recording all of your experiences, from reflecting upon, say, a taster week in a specialty to logging all of your surgical procedures in a formal logbook. This is something that I got introduced to, which is now, because of COVID, a larger part of your portfolio for a specialty training position, because interviews aren't very much possible in person. And these are things that recruiters are now, well, the national recruitment system is now looking at more this year, especially because this year's specialty recruitment also had fewer positions on offer because of COVID. So yeah, I think there has been a bit of a paradigm shift as an effect of COVID on training here.
Of course. So we got to learn about your journey, Dr. Arish, in terms of, let's say, the practicalities and the self-discovery that you had in the Netherlands. But what would you say in terms of the personal challenges that you faced, both inside and outside of training, while you were, embarking on this journey, while you have been on it, and maybe currently as well?
Hmm. Um, so it takes a bit of realistic thinking as a medical student also when it comes to making choices for one's career. Having a good MBBS degree from a good reputable institution in Pakistan does not come cheap. And that is something I feel not just I think about because to be honest, I never had to think about it as a medical student. That thought never occurred to me. But then speaking to my fellow students, the variation of people that we have at AKU from all sorts of different backgrounds, it hit me as to how much we take for granted just money
Yes,
and how much of I wouldn't call it a burden because no parent wants to call it a burden, but how much of a thought at the back of one's mind it is to get your kids through university and then getting them through a lot of the other steps of becoming a trainee physician. So for a lot of people exploring postgraduate training abroad, one of the more sensible options can be the UK because I have a lot of people who come to me and say, listen, we just simply don't have the funds and we want to be well trained. So one of the reasons why people can explore places like the UK or Europe or even Australia is that. The second thing I think is uh, a lot of it to do with one's mental health.
absolutely.
Um, we've I have some a lot of seniors from our AKU fraternity who are surgical residents or faculty in the US. A lot of them are sitting in the room. I believe I am talking to, but can't see. A lot of them are now in the UK, who I have been fortunate enough to get in touch with. And overall, I feel everybody's been through their own struggle, absolutely. But there is a bit of the human aspect to it, as to it's not just being all work and not always being sleep deprived and not always being challenged in the sense of your own mental health or mental peace. So I find the UK, even though yes, the years are long, but the weeks are nicer. The workload is better. My sister makes fun of me and says that I'm off. I'm basically on holiday for half the year and then I work half the year, which is a little far from the truth. It's not completely true. But her having trained in the US looks at me and she says, "तुम कितना काम कर लेती हो? तुम क्यों नहीं करते हो काम?" I'm like, it's not like I'm not working. I am working. It's just that I have time to do other things
Yes.
more per se. Maybe she did when she was a resident in the US. Um, so that as well is a big factor to it. I think as human beings, we need to explore a lot of aspects of ourselves, not just professionally. So on a personal note, I think that's also something that people need to take care of. And then what is most important outside of surgery for me, I want to be an ENT surgeon, and yes, surgery is a big part of my life. But outside of work, I think to the average medical student in Pakistan as well, I would say having a life is very important
Yeah.
because as a medical student and as a trainee or even a professional, you will want to have opportunities to travel, to meet people, to be part of student societies, do stuff aside from the books. And I know this entire session has been amazing. It's very informative. But as a young trainee and as a medical student, Dr. Adil Haider was absolutely right. You hear about all of these robotics and this, that, and everything, and it becomes overwhelming. So as a medical student in Pakistan, you have to give yourself a break, really step out of the rat race, not just emotionally, stand up and take a step outside and tell yourself, okay, listen, it'll happen. You are all hard workers. You've always been. You are medical students and you पढ़ाई लिखाई हो जाती है, but you have to remind yourself there is no time limit to it. everybody is in a rat race to be a consultant by 30. Listen, 30 is nothing. I'm almost there, I think, but I have like all of our seniors keep telling me this. Listen, take your time to be a well-trained, safe doctor who takes care of patients, but you will do it in your own time. So that's something that really falls close to my heart because I've seen people completely destroy their mental health in the pursuit of just doing better or getting ahead or being part of
Just
it.
getting there faster, exactly. I think this is what I'm been so honored to be able to interview you because your answer just answered two of my next questions, which was about what to do outside of surgery and how to build up that scope. So I'm going to wrap it up. Firstly, thank you for such an insightful lens and such good advice, because the whole point of the student session is so that one can relate, and you've allowed us to relate. So I'm just going to wrap it up and ask you to give one or two final pearls of wisdom, and then we're going to move on to our panel discussion.
I'm saying this with knowledge that a lot of our mentors, who at least we've met as APU students, are very well, have backgrounds in the US or maybe backgrounds in specialties where they've developed themselves in a very busy schedule. But to all of the medical students who are listening on to this, there is no one right way of doing things. There are a lot of options out there. So please don't pressure yourselves into doing what everybody is doing. There are a lot of options to explore. There's a lot of different pathways where you can get where you need to be, where you want to be. And B, don't get overwhelmed at this stage, or actually don't get overwhelmed ever, but especially as a medical student, you're only 18 to 23, 24. You are in a point of time where you must explore what your passion is, like my seniors just said before me. And you will only find out that passion by exploring new experiences. Go to the ORs, go to clinics, go to do a lot of stuff, do research if you want. Like Dr. Professor Saad Umar is a brilliant public health scientist, and he didn't take the clinical pathway. So please explore yourself as medical students, reach out to your seniors. We're always around, and I'm actually quite happy to say this, that as an ATU alumnus in the UK right now, we've been able to form a platform where almost all of our ATU graduates in the UK are, and who are more than happy to mentor students, not just AQ grads, they'll be able to mentor students when when approached. So we've got excellent cover from our previous, I'm not going to say generation because that'll make you guys feel too old, but seniors. Uh, and don't be afraid to ask questions. Don't get caught up in the rat race, and really explore yourself are the three things I would say to the medical student at this point.
I don't know about everyone else, but I'm surely feeling inspired. And thank you for that, Dr. Arish. It's amazing. It's been wonderful to have you. And we hope to be in touch. And that's fantastic news for everyone here. So do reach out. So we're going to
Yes.
move on. I'll pass it over to Ronika. Thank you, Dr. Arish.
Thank you.
Thank you for that detailed discourse, Dr. Arish Haider and Aisha. And thank you, Dr. Adil Haider, for raising an important question reflecting the training provided here at AKU. Up next, we have a panel discussion titled Transitioning into a New Era. The discussion will be moderated by our very own Mr. Manzar Abbas. Mr. Manzar Abbas is a third-year medical student at AKU and is a co-member of Surgery Interest Group. Ladies and gentlemen, please help me welcome Mr. Manzar Abbas.
Assalamu alaikum and good afternoon, everyone. So, thank you for joining us in the panel discussion with our own doctors and mentors. Let's start with the quick introductions. First of all, we have Dr. Lynette Dominguez. She's a trauma surgeon and a surgical advisor. She's joined Medicine Sans Frontiers (MSF) in 2005, and she participated in the MSF post-tsunami relief surgical program in Indonesia. She has a history of working in non-profit organizations, administrative management, and surgical skills. Next on the list, we have Dr. Alize Abbas. She's a graduate of AKU 2018, and she's an aspiring academic surgeon. She's a global surgery research associate and research lead at General Surge. She's also the co-founder and co-chair of Incision PK. Next, we have Dr. Marvi Tariq. She's a graduate of AQ class of 2017, and she's currently a categorical general resident at University of Alabama. In Aga Khan University, she was the secretary of Surgery Interest Group and the co-convener of Student Research Forum. Next, we have Dr. Maheen Janjua. She's a graduate of AQ class of 2018, and she was one of the founding members of SIG. So please help me in welcoming all these panelists, and let's start with our questions. First of all, thank you all for joining, Dr. Lynette, Dr. Maheen, Dr. Alize, and Dr. Marvi.
Thank you. Thank you.
Okay, so first of all, I know all of you are doing some great work, either as a consultant or as a wedding surgeon. So how is your journey to the point of medical school to where you are right now? And what are some of the best and most challenging aspects of your training? Let's start with Dr. Lynette first. Dr. Lynette.
Okay, well, you know, surgery is one of the longest career paths that anyone can take. And I really felt that as a surgeon, one of the most challenging things is if you compare yourself to other professionals, we are delayed in our personal and professional growth. We don't start earning until we're quite older than others. And success comes at a cost. And I think the most important and challenging thing during my training was really just finding the balance between all the workload that they're giving you and also spending time with your family and developing your relationships with your family. So I think I also made mistakes. I mean, I also neglected a lot my family, and what you do is you just try and get up again. You learn to adapt to a very difficult environment where there's a lot demanded from you from your workload.
Thank you, Dr. Lynette. Next, Dr. Maheen.
Assalamu alaikum, everyone. First of all, thank you so much for having me over. It's an honor to be one of the speakers. As for my journey, I think well, it's pretty clear. I graduated in 2018. Soon after, took my steps and joined Dr. Adil Haider and Dr. Mahim Malik on the on doing research. At least that's what was my actual position that was called. But I would say that it was a very diverse experience that I had working as a research associate with Dr. Adil Haider and Dr. Mahim Malik, because not only was I involved in research at that time, but I was also working with the dean of the medical college, and I was working with a new attending who had just graduated from her fellowship, and obviously she had been in practice, but both of them kind of gave me a very, I learned about how to deal with people and how they deal with as leaders, as members of a team. And I think that's something that really helps me now, even as I entered into the surgical residency, which I matched into soon after. Because I will reiterate this again. I think what I've figured out after a couple months into residency is that residency is a lot more about, it's about 60% of how you deal with people and about 40% of how much you know and what you can learn in the operating room. And these are life skills that you will be learning along the way. So I guess some of the best things and the most challenging things can kind of overlap. Surgical residency is not a joke. It is very tough. It kind of pushes you to the limit, but I think that's also kind of exciting. it was definitely a challenge moving from one country to the other. It was challenge in terms of what COVID brought. We weren't really expecting that, but a whole year of COVID, having practicing medicine in a way that I hadn't been exposed to in medical school, and and then just the fact that you are an international medical graduate who's matched into the US, you are the only international medical graduate in your class, and then you have to make you're not only representing yourself when you're performing, but you're also representing every other IMG, every other international medical graduate who will be coming up for interviews. So you want to put your best foot forward, and I think those were some of the more challenging parts. But when you kind of succeed in doing that, that was one of the best parts. Um, I think my goal in the talk today might be to kind of let everybody know that we make mistakes, that we fall, that we cry, but at the end of the day, we make it, and it's all about perseverance when it comes to getting into surgery.
That sounds interesting, Dr. Maheen. Next, Dr. Marvi, can you please talk about your journey and the challenges faced till the medical school to the point right now?
Hey, yeah, thanks for having me. Can you guys hear me okay? Well, challenges. So I graduated in 2017, moved to the US soon after, started my postdoc in cancer immunology at Emory, and then matched into the categorical general surgery residency at UAB. The first challenge, honestly, is really just matching, and everyone takes a different path to it. One thing that I noticed very early when I moved to the US for just my AIs, and something that I worked very intentionally towards changing soon after, was really just the perception that people had of me. And that differs really, I think there's a lot of different medical schools across the world, and they train different kinds of doctors. So it's hard to expect US attendings to know what to expect. So the first time I met somebody while interviewing for a postdoc, they asked me if I knew what Microsoft Excel was or how to use it. And some folks might not know that still, but that made me realize how much I had to prove in order to really get hired. And once I did get the postdoc, my main mentor still didn't know me very well because I was hired by surgeons to work for a basic scientist. So that's a dynamic you really have to work to make sure you make a very good impression right at the beginning, because that sticks. So I think those are challenges, and really, I do think Aga Khan trains us well enough. I have never once, I'm 7 months into residency, have never felt that I wasn't adequately trained in anything. That's just not a thing at Aga Khan. It's really more just about holding your head up high and not letting the insecurities, or really just the perception that you have of yourself that you are the only international amongst all these people who went to these really big name medical schools across the US. You just have to hold your head up high and know that you're adequately trained, and then act like it. And the rest of the values that AKU really inculcates in you, you just gotta hold on to them in residency. COVID obviously made things harder. And I think from a surgical residency standpoint, one was really just moving to a new city and not having the chance to meet anybody or explore anything. You're at home, and then you're at the hospital, and then you're at home again. And then in surgery, a lot of our elective cases shut down. So then there's always this fear that you're just managing the floor and not really operating. And then there's the risk that you'll get pulled to manage the medicine ICU and all COVID patients and not really the surgery. So I think there are certain challenges that came with the pandemic, but most programs, I think, handled it quite gracefully. Thanks.
Great. Thank you, Dr. Marvi. Dr. Alice?
Hi, Assalamu alaikum. Thank you so much for having me. I'm so excited to be here. I remember the very first annual surgical conference that I attended back in second year or third year. And I'm so happy to see how much more student involvement we have for over the past few years. So I'm not in surgery residency training yet, but I think I'm going to talk about my journey and where I am right now. So I graduated in 2018. And so I decided to take a path which was, and that is possibly one of the challenging aspects of my journey so far. I wanted to do something slightly different from what most people do after graduation. I wanted to dedicate my time to doing global surgery research. And so I started working as a global surgery research associate at the Indus Health Network. And so while I did that, I think my love for global surgery came from AKU, because I do know that even though AKU is a large tertiary care hospital and we do see people from all walks of life, one of the best things that AKU does is making sure that we also do go out to outpatient clinics in a lot of urban slums within Karachi. And so it was in one of these clinics that I met a patient who really left an impact on me, because I saw that that clinic was merely 20 to 30 minutes away from AKU, but or any of the other big hospitals in Karachi, but that patient still did not receive care till the time that that patient had a leg wound, which was infested with maggots. And I can never forget that. So building onto that, I realized I made a very conscious decision that this is something that I want to do after I graduate. And so in all this time, I think one of the best things that I've had the opportunity to do is see how my global surgery research work that I do has had the potential to really impact patient care. Because some of the things that you're doing in research, of course, that's giving you skills, that's helping you know about the existing literature, that's helping you make an impact. But if you can see that this is how these many people can be, their lives can be improved, that was one of the most rewarding experiences. One of the other things was, of course, getting to meet people from all over the world. And this is something that of course, this is not an easy thing per se, but of course, I think everybody would agree here that this is one of the things that COVID has really helped us with, increasing the interaction that we have with people from all over the world over Zoom and video calls. And that's one of the things that I got to do as well. For example, I'm part of an initiative, the Gender Equity Initiative in Global Surgery, where we're trying to increase representation of women as well as other underrepresented genders and groups in surgery. And so everybody, we've never met one another. There are people from all over the world, and we're doing this all over an online conference or an online meeting like this. But I will say, even though these things are very rewarding, there are always challenges, like everybody has mentioned here. So one of the things that I would mention, and the reason I mention it is maybe because just to tell everybody that it's okay, you may face a similar challenge, was really having to own your path, knowing that what you want to do is okay and it's correct. So if it differs from the 99% and what everybody else wants to do, that's okay. If you really believe in it, and if you know that you do want to be a surgeon, you want to help people, but you just want to do it in a slightly different way, that's okay. So that's one of the things. And then, of course, finding like-minded people and mentors who really do believe in you, who tell you that, yes, if this is something that you believe in, and giving you the opportunities. But Alhamdulillah, I was fortunate to find these people who gave me the opportunities. And so I was able to make a contribution, even though small at the moment. But so that's basically what it was like for me.
I totally agree with Dr. Elisa. You need to find like-minded people who can mentor you and give you opportunities. So thank you. Let's move on to the next question. So each of you have received or are receiving some surgical education from a diverse background. What was unique about your experience within surgical education that helped you in further improving your skills? Dr. Lynette, can you please start?
I think what was unique about the training that I underwent was from my country, we're 7,107 islands. And therefore, part of our training was going to these remote areas in the Philippines where nothing was in place. And you had to live in a hut with holes. And you saw up to 700 to 1,000 patients a day, you and your fellow students. And sometimes you felt stranded and abandoned. And you learn to find solutions because of the limited resources that you have. There was so much lack of structure and formalized organization. You had to put structure and organization in place. You had to be very resourceful in finding solutions in less limited resources. And also, I think what was unique about my education was I went into trauma surgery when this field was not so popular. You don't make money in trauma surgery in my country because most patients who arrive in the emergency room who are victims of a gunshot wound or traffic accidents, they don't have insurance. There is no money. And you would do around 5 to 6 laparotomies per day for stab wounds and gunshot wounds. And when I finally ended up working with Doctors Without Borders, you arrive in the middle of a war, there's nothing in place, and all these things that I had learned during my surgical education, planning the hospital, planning the layout, setting up the triage and the flow of the patients, making an admission criteria, and at the same time hiring the local staff who are not educated and training them to become surgical staff. I think that really helped me because I came from a background where you had to work with limited resources. I never thought that I would end up, for example, traveling around the world and becoming a war surgeon in places of conflict and of war. So I think what really helped was just really having a limited resources background and then finding solutions to these problems. These helped me with my career.
Thank you, Dr. Lynette. Dr. Maheen.
So I would say I stand in a very good position to talk about the diversity because my program particularly is one of the biggest representatives of the African American community in the United States. And that helps me get a perspective on what it's like to work in a minority, a hospital that's been made to serve the minority. It has been made to serve the underserved. And the people that I work with, we are a very diverse group of people coming in from all over the world. We are a very colorful group, as we like to call it. Even though I'm the only IMG in my particular class, but I have a number of people who've come from the Caribbean islands. I have people who've come from India, Pakistan, and all of them are bringing in something from their background, something that they've done before. A lot of people have come from Africa, and a lot of these people have already done a number of years of training in their own countries. So when you start working with them, you start interacting and you start learning about what's been going on in their countries, what's worked for them, what's worked for particularly making use of lower resources and how they've made an impact on patient care. So particularly in my residency program, because I'm quite fresh into the residency, I cannot speak for what goes on in other residency programs. But for us, it's like from the level of the housekeeper till the level of the attending, we should be knowing how to do everything. So if we can't get, if the nurse can't get an IV line, we're expected to have the IV line in, we're expected to draw the blood, we're expected to have everything ready for our patient to get better. If something isn't done, then the fault falls on the resident, it falls on the team that you weren't putting in the right amount of effort. Couldn't you do it? So that kind of pushes us to not think of anybody inferior. And it also helps me develop skills that I previously did not have. I do think that that Aga Khan University has trained me very well, like Marvi said, in making a difference in terms of when I go in and I start working around with my patients, I am able to give them the world-class care that they would receive from anyone who would have graduated from the best university in the United States. So that helps me stand out. And I think that was one of the important things that I want to hold on to from my background, the work ethic that I bring in, the fact that my mentors taught me not to make the same mistakes twice. If they've taught me one thing once, or if they've shown it to me once, they would expect me to be able to do it the second time and be able to teach it the third time. So I'm very much following that same principle. And that does become overwhelming at times when you haven't done something before and now you're supposed to do it for a real patient. You're supposed to document it. You worry about the liabilities and everything, but definitely it serves a huge role in helping me grow every day, every moment that I'm at the hospital, and even when I'm out, and in becoming a better surgeon.
Right. I really like the idea of like teaching someone, then they will teach someone and they will teach someone. That's really great. I'll definitely follow that. Dr. Marby, how's your experience different, like in different, from different backgrounds and different surgical, diverse backgrounds?
Well, I think Aga Khan teaches you to manage and interact with underserved populations. Despite the fact that it offers really great care, you still see a lot of people in CHS and other off-site clinics that you do. And the hospital that I happen to work at is really the only major tertiary care center that everybody who has a really complicated problem gets referred to. And in Alabama, you'd be surprised that there's a lot of areas that don't have very high literacy rates or don't have access to great care. So a lot of times the patients that get referred to us are in pretty bad shape. And I think really a lot of times other residents are really just shocked at that. But having trained in Pakistan, I think my background there really helps me get over the shock relatively quickly and get to empathizing and sympathizing and actually taking care of them. So I think that's really helped for sure, because the populations that we see back home and the populations that you see in a lot of areas that don't really have great access to care in the United States are actually very similar. So I think that's a plus for sure.
That's great. Dr. Alize.
I do agree with what everything was just said. I think one of the other things that I've truly felt is that, and this was something that has been discussed, this has been the recurring theme for this conference, and I think that's really important to talk about, is what else is important for you to become a good surgeon, or rather for you to become a good doctor. Of course, you need to have the basic skills, and if you're going to operate on somebody, you need that. But then there's everything else that's basically under the patient-physician communication, how you communicate with the family, and just having an understanding of what is happening outside the hospital. Because if you're working in a setting, especially if it's a war zone, I mean, you have to know the situation before you can make a change. And I think, for example, going through AKU made me understand how that is so important, how the things that are happening outside the walls of AKU also impact or should impact the thinking of all the doctors and trainees and students who are working within AKU. And I saw that happening because I think the reason that that's important is because when we're trying to make a change, or when we're trying to do any research, and there's this concept of, for example, researchers from a high-income country working in for a few months or a few years in a low-income country, then there's this recurring theme where do the researchers even know what's happening on the ground for them to make a change? And if they don't know what's happening on the ground, can they really make a change? So one of the things that I really learned from being a medical student was at AKU that you have to understand what the community wants. And for example, I remember we went to a camp for internally displaced people, and that was a completely different setting that I don't think anybody from my whole class had experienced before. So those things stay with you. And when you're put in a situation like this, whether that's in training, whether that's as a researcher, you know how to think because you have been exposed to that setting. And so these things are really important because not only do they improve your on-paper skills, or rather your skills and knowledge about doing research, but also how you would interact with a patient, how you would make sure that no patient fall through the cracks. So if the patient can't come to you, how can you reach out to them? So this was some of the things that has really helped me working as a global surgery researcher at the moment. And hopefully, definitely, I do want to make sure that I live by these principles and make sure that I incorporate them as a surgical trainee and as a surgeon.
Thank you, Dr. Alize. So next question we have, how do you see surgical education changing in the upcoming years, both in Pakistan and abroad? And if you see any changes, what do you think would be the pros and cons of upcoming innovations in training? Like Dr. Leonard.
Well, first of all, I'd like to say that surgical education is, I think, much easier in some ways. For example, you have a lot of online learning education tools, which were not available during my time. And now if I want to learn something, I can enroll in a course. I can watch videos which are available on different websites and also on YouTube. So things have gotten a lot easier. Also the books and the apps that are available on your mobile phone. You know, I used to carry huge surgery books, anatomy books, and now you go to your phone and you have the 3D model of the human body. If I want to know, if I'm in the middle of a war and there's internet and I want to know the vascular supply and the collateral supply of your humerus because I want to repair this blood vessel, and then what's the collateral supply? What's the incidence and prevalence of a blood clot forming? What's the incidence of ischemia? All these things are available online. So I think that right now you have a lot more opportunities, a lot more options to learn new things. And you know what's really nice also, that right now you can bring small tools to the field. Right now you have these small ultrasound machines that are the size of your cell phone, which right now we're still studying whether or not it's applicable in the field because the batteries last only 1 to 2 hours, and then who's going to repair them if they break down in the middle of a war, so, or in a remote area. So all these things are very challenging, but you know, a lot of new ideas are coming. Like for example, you know, the plumbers, they use these endoscopes when they try to fix a blocked pipe. And now these, it's very portable. You can bring them in your pocket and you can use it in the field, for example, to remove a foreign body in the nose or in the throat. So all these apps and things which make life easier for you as a doctor, they make you a better physician. For example, you know, Starlink, everybody knows Elon Musk and Starlink, where internet is available everywhere and it's going to be very fast. So these are very, very good because they give you the tools to work in remote areas. What's not so good is because of all these tools, the lack of hands-on skills, I think, is lacking. There's still lots to learn aside from the skills, the human interaction, the cultural adaptation, how to change yourself, you know? And what's really nice, I think, is to develop tools for mentoring younger students from afar. And even within MSF, we're still developing these tools. How do you send an older surgeon, for example, with a younger surgeon in the field to learn from the older surgeon? And because of COVID, you know, older surgeons can't go to the field. They're not allowed to, because the possibility of them getting COVID in the field is very high. And if you have hypertension or asthma, how are you going to be evacuated from the field? So it's always a balance, you know? And so with new innovation also comes new problems.
I totally agree with Dr. Leonard K. With upcoming technology, we are advancing, but we really need some hands-on practice and cultural balance. Dr. Mahin, what do you think about the advancements in this field?
So I completely agree with Dr. Lynette on this. I think we are very blessed to be in an era where everything is just a touch of a finger away. We can, even if you meet any resistance or any kind of confusion when you're standing in the OR, you can just take a pause. You can look up what's going on. You can find out more information rather than having to open a book. Having said that, I think some of the innovations that will soon be coming to Pakistan, I think, is the robotic surgery, and I look forward to that. Which is why I think that was one of the main reasons why I wanted to train in the US, particularly because I knew that they had started training in robotic surgery and they were doing most of the surgeries robotically, or at least moving towards that. Even though the problem with that is that when we work with surgeons who are mostly doing robotic surgery, we as residents are not getting enough hands-on in terms of getting our laparoscopic skills in or doing more open cases. So I think we still get to do open cases because we are a trauma-heavy center where we do laparotomies, and usually, especially our senior surgeons, are not very comfortable with the laparoscopic approach. And when it comes to saving the life of a patient, the open approach is what we definitely go for. But in elective cases, whether it's cholecystectomies or appendectomies or inguinal hernia repairs, now there's more data coming in which is supporting robotic surgery. And I think there was one of the conversations that I had with one of our chairs is that, and I'm kind of excited about this, is the fact that robotic surgery has come in not only increases the lifespan that a surgeon can work for, because there's more stability, there's better vision, there's better ergonomics, but at the same time, what I'm looking forward to is having collaboration between the United States or other countries where robotic surgery is pretty heavy, and having them remotely work on patients in underserved countries, including Pakistan, where a surgeon sitting all the way in the US can somehow move around and work on their robot, and the machines will be like the robot will be present in Pakistan operating on a patient. And I look forward to that time. So definitely we have a lot of innovations that are coming in which will be helpful, but whoever is going into residency needs to understand that you will have to put in an extra effort to gain the skills that all our seniors attendings already have in terms of not tying, going into the OR, looking at doing the stuff yourself. I think that's something that is going to be a challenge.
That's great. Even I'm looking forward to robotic surgery, and I really like the idea of like remote surgical procedures. Moving forward to Dr. Marvi, what do you think are the advancements in the in the field, and what are the pros and cons of these innovations?
All right, so I'm going to talk about this from an intern perspective, and start simply with saying when you go to the OR, you have to earn the right to do something in that case. Which comes with a bunch of things. You can't just expect that your attending will let you do everything. So obviously preparation, so know your patient, know the disease, know the anatomy, know the path. But then also with these new innovations, so for example, laparoscopic or robotic surgeries, there's some training time that goes into it before you get into the case and they actually let you do stuff. And there's wonderful modules for robotic surgery and then laparoscopic like FLS. And there should be sim centers and at least most big centers where you can practice those skills before you actually go to the operating room. Because if the first time you sit on the robot with your attending is your first time sitting on the robot and you don't know how to move anything around or what pedal to press, that doesn't give them a lot of confidence to actually let you do the hernia with them. And I've seen cases where interns who actually knew what they were doing were allowed to do the major chunk of an inguinal hernia, which is a big deal for an intern doing robotically. So that is really just the investment that you make in yourself by actually preparing before the case. So as these new innovations start, you'll just have, initially it was what, 10,000 knots, practice suturing, practice knot tying. Now, in addition to that, you have to do all your lab skills. So the three major activities that go with FLS, like pec transfer, intracorporeal suturing, all of that stuff. And then all your robotic modules, and you need to have them done before you actually go to cases and try to get your attending to let you do stuff. So I think that's one additional thing that we all just really have to do with these new innovations to actually be able to learn well. And then potential issue, like Dr. Lynette said, we're more hands-off now. And everything is becoming more standardized, at least in bigger centers. So one thing that UAB recently was considering was making the CVL team. And we already have a procedures team, which is internal medicine that does a lot of procedures like paracentesis. And that's concerning for surgery residents, because if you don't know how to do a CVL, because there's a team that does it for you, and then you're an attending and you're in a low resource center and you need to put a CVL and you haven't done it in 5 years, that's a problem. So as things become more standardized, I do think we'll have to fight a little bit to make sure the skills that you're supposed to learn in residency are actually learning adequately. So by the time you graduate, you're very well versed in all the basic procedures that you need to be able to do. And then in addition to just these like procedural teams, there's obviously in the US at least, there's PAs, CRNAs, a bunch of other people in the OR. So there's less for you to do and you kind of have to push their hand in suture sometimes. And then I guess the last thing would be in trauma, at least we have ED residents. In the surgical ICU, we have anesthesia residents. And it's really not a turf war per se, but we've gotten to a point where we have high volume of cases, but also just a lot of trainees and other staff in hospitals, at least those with resources. So it's really up to the surgical trainee to take their training in their own hands and make sure that you have a set objective for every rotation, and then make sure you learn that thing, because nobody owes that to you. There's no guarantee that you'll get through a 1-month rotation and know what you're supposed to have learned. So I think taking more initiative and trying to learn all those things is important. And those would be my 3 main points.
Thank you, Dr. Mavi, for the detailed answer. Dr. Elise, how do you see the surgical education in upcoming years, and what are the pros and cons?
Thanks. I think that's a great question, especially for medical students, trainees, who still haven't started surgical training yet. So I think one of the things that I've really noticed in the past 3 to 4 years is the increasing use of social media, and how that has really encouraged, or rather allowed students and trainees from different parts of the world who may not have the opportunities to get involved in more sophisticated surgical education opportunities. And I say that especially in Pakistan, where I feel that there's a lot of heterogeneity that exists within medical education. Not every medical school would be equipped with a stimulation center, or even just faculty who's well versed with that. So of course, we're very fortunate to be at AKU, where we did have an insight into how these things work, even if it was not as much as it would be for a resident, for example. But I think, so social media, especially Twitter, has played an important role. And one of the other things that I'm seeing is, in addition to online applications or other residency-based modules that will increase your exposure to these things, there's also an increasing emphasis on people from different parts of the world working together in trying to achieve these things. And for example, recently in a study, we looked at the impact of COVID on how that has affected pediatric surgery training and fellowship training. And of course, one of the things that kept coming up was that there's decreased hands-on, and then there's decreased hands-on. And there was the solution to that was that you can do more stimulation, you can do more online discussions. But then one of the problems, as was rightly mentioned by all the other panelists, was that it is not going to replace hands-on experience. That will only come when you do that. So that is definitely a challenge which cannot be denied. But I really do see the fact that in some parts of the world, in even a lot of parts of the country, it will take years for these things to come, and not everybody will have access to these resources. So I feel that the onus of trying to improve medical education as a whole in our country, Pakistan, is possibly on those who do have access to these resources. And I know that, for example, AKU and SIG have been really trying to develop a network to improve medical students' engagement in surgery-related activities over Pakistan, and I think that's a great initiative. Similar to that, we at Incision Pakistan, which is, for anybody who may not know, that's the International Student Surgical Network. Last year, we launched the Pakistan's National Working Group, myself and 2 of my colleagues, and what we've been really trying to do is also increase access to mentorship. Because if you don't know about a certain thing, then you would not know how to go about trying to get those skills. So I think that's really important. If you have the right mentorship, then that broadens your horizon, I think, most of all. And once you know about it, that's when you can say, okay, this is the skill that I want. This is the kind of surgeon that I want. So I think these are great things that are happening, especially because they take away the geographical barriers, sometimes the financial barriers as well. And I really do think that this is going to be for the better, the changes that are coming in.
Thank you, Dr. Elise. I think we are running out of time, so it's time to conclude here. I really thank Dr. Lynette, Dr. Mahin, Dr. Marvi, and Dr. Elise for taking out time for us and having a wonderful session with us. Thank you so much once again, and Allah Hafiz. See you.
Thank you.
Thank you very much. Thank you
so much. Thank you.
Bye.
Thank you, panelists and Mr. Manzur Abbas. Thank you so much for coming out today, ladies and gentlemen. Our session is in its final moments now, and to sum it all up, we would like to invite an inspirational surgeon to the podium. Dr. Ather Enam is a US board certified neurosurgeon. Currently, he is a professor of neurosurgery, chair Department of Surgery at AKU, and patron of Surgery Interest Group. Dr. Enam has also been awarded the Sitara-e-Imtiaz of one of the highest civilian awards of Pakistan. He is also trained with a PhD in basic neuroscience, along with being the founding member of Pakistan Society of Basic and Applied Neuroscience. Please give a huge round of applause to Dr. Ather Enam, patron of Surgery Interest Group.
So wonderful session, amazing. When I was young, I remember my Abhijan. Abhijan is like, we used to use the term father. It's a Persian mix, right? Abhijan. He used to say, Honhar barwa ke chikne chikne paat. Honhar barwa ke chikne chikne paat. Meaning that when you're young and if you look at the form of that plant, it's going to be a great plant because the leaves and everything is in perfect shape. And that's how I feel about the SIG students. It's an amazing group that brings energy, enthusiasm in here in our life. So it's a pleasure, it's an honor, and I wish that and actually it is spreading across to other institutions also, what you guys have done. So I hope that this goes across. So we had a wonderful session, a wonderful keynote by lecture by our dean, an AQ alumnus, a surgeon. And he talked about his journey, but the quality of a good mentor is that he gives the mentee the confidence that he or she too can achieve what that mentor has achieved. And Dean Adil Haider has that ability that when you talk to him, you feel like, you know what, I think I can do that also. So that's the connection that a good mentor provides, and he does that. So this is an SIG session, and you can imagine how important this session is, that the dean is still here till the end. So Dr. Adil Haider, we really appreciate, because usually what happens is that, the big shots like you guys, they just walk away after giving their keynote lecture. So we are thankful for that. We had a great lecture by Dr. Ghulam Abbas, who took us at the edge of reality and sci-fi, except for the difference that the reality is encroaching into sci-fi at a breathtaking space. Arish's work and COVID and his award by the Prime Minister. Did we mention that part? No, we did not, right? So that's an amazing, inspiring story, what Arish was talking about, how you have to go beyond yourself. And that's what we see in the medical students nowadays. His advice to every medical student of exploring, which brings me to this point that we are all AQ medical students over here, and we are all talking about how great it has been at AQ, how AQ has given all this to us. But to all those medical students who don't belong to AQU, I would like to say that it's not that they can't do it. It's just a matter of exploring, as Arish mentioned, and that's what we found in the panel discussion by Lynette Dominguez and Mahin Janjua and Marvi Tariq and Alize Abbas. Although 3 of these 4 were from AKU, but they also gave the same message that it doesn't matter whether you are an AKU or another medical school in Pakistan or in any other part of the world. It's you have to have the passion, you have to have the direction, and you will find what you're looking for. I think we need to mention the names of the SIG conveners in the past, how Aisha Kudusi made this SIG a reality. Arish Haider was his convener, then Aisha Tariq, then Muhammad Ali, and some of the leaders of the SIG, including Fatima Mustansir, Mahin Janjua, Abdullah Arai, Marvi Tariq, Ajia Sayyed, Shahmir Chauhan, Aisha Noor, Nabil, and Burhan, and the legacy goes on. So wonderful job, SIG. the life in AKU is really worth because of you guys, the energy and the enthusiasm that you bring. Thank you very much.
Thank you, Dr. Enam. Ladies and gentlemen, that brings our student session to an end. This could not have been possible without the help and support of many people. Dr. Ather Enam, Dr. Sadaf Khan, Dr. Amir Sharif, Dr. Hamad Ather, Dr. Abida Sattar, Dr. Adil Haider, Dr. Gulzar Lakhani, and Mr. Sharif Chirania. Thank you all for everything you have done. This session would not have been possible without your invaluable input and advice. Sharif Bhai, we are truly grateful to have you. Thank you for always helping us behind the scenes and making surgery interest group events a success. We would also like to specially mention and thank those who have worked day and night amongst daily schedules and because of whom this event would not have been possible to conduct in a smooth manner. Please give a round of applause to the surgery interest group and the student body, our volunteers and staff members. Hope to see you all again next year. Thank you all for joining us.